Okay, so today we're going through week 9 and the focus is pharmacology. We'll be going through an introduction to pharmacology, pharmacokinetics, ANS drugs, envenoming, and then anti-cancer. Malika. So how to study pharm. This is just kind of a very brief talk about how to study pharm because a lot of it seems like memorization and it can be hard to find resources. So firstly, I would recommend the ePharmacology website, and it's quite accessible. You just need your Monash email, and what it is basically a collation of all the drugs that you need to know by the end of year 5. And there are quite a lot of them, but you will eventually work your way through, and it's kind of like a dictionary for all the drugs. And all these drugs are core, so you will need to know them, but not at first year. Any drug that is on there is technically testable. So I would definitely have a look, especially when you're confused about the mechanism of action or the adverse effects. It's just a very good summary. Another one is the electronic therapeutic guidelines, and that tells you the clinical usage of each drug. And that's more relevant the further you go along. As for memorizing drugs, different people have different ways of studying, of course. Anki is a very popular software for med students particularly, and it's basically a digital flashcard that uses spaced repetition, or you could just use normal flashcards if that's more your thing. Mnemonics are also very, very popular. There's a whole lot going around and you can make your own, but there are also some kind of tried and true ones that you can also learn. Drawing concept maps and summary tables are kind of another good way of learning more actively. You can also find these floating around, especially on the Moonish Drive. PSPs have some, we have some, or you can make your own. But I guess I really want to emphasize that you really should understand the big ideas before you get into memorizing. And a lot of the information you're presented with is more than you need to know. But having a general understanding of things like the mechanism of action, grouping drug classes, and understanding why adverse effects happen will really help in the long term and short term, really, in terms of memorizing the drugs. Yeah, that's all I have to say. I'll pass on to Malika.
Great, cool. So Stella already went through what we're covering today. And so start with intro to pharmacology. So a few definitions. So a target is what the drug acts upon. So these can be like ion channels, enzymes, transporters, receptors, or anything. And then specificity and selectivity, they sound pretty similar, but they're quite different. So specificity is when a drug acts on receptors on a specific organ. Selectivity is when it acts on receptors wherever the receptors exist in the body. So most drugs tend to be selective rather than specific. And for affinity versus efficacy, so affinity is the strength of binding of a drug to receptor. So basically how strong it binds. And efficacy is how capable the drug is of producing a response. So drugs generally have generic names and brand names. So when a company invents a new drug, they can patent it. So that can last for several years. So this allows no other companies to make the same drug. And so the original company can make their money back. But once the patent expires, other companies can use the same active ingredient to make their own drugs. And so, for example, paracetamol is the generic name, but the brand name would be like Panadol. So agonists versus antagonists. So agonists are drugs. So both kinds of drugs bind to receptors, but agonists activate the receptor, while antagonists just block the receptor. So they have very high affinity so that they can bind to the receptor, but no efficacy at all. So they just stop other things binding to it. So there's a few phases. So the pharmaceutical phase is basically like how the form of the drug being delivered, so oral or intravenous or anything like that. The pharmacokinetic phase, which we'll talk a bit more about in a bit, is basically what the body does to the drug. And the pharmacodynamic phase is what the drug does to the body. So the pharmacodynamic phase you'll learn more about next semester. So there's lots of routes of administration, but oral is our preferred route because patient compliance is higher. And there's a lot of other routes listed there, which I'm not going to read out, but like injection, sublingual. And the reason you might want to use one of these apart from oral is that the drug is unstable or it's inactivated in your GI tract, or vomiting or the disease state interferes in absorption of the drug. Or if the patient's unconscious, then obviously they can't swallow a pill, and to avoid any systemic effects. So oral absorption is affected by drug properties, so the form of the drug, tablet or capsule or ointment, however it's delivered, dispersion and dissolution of tablets, lipid solubility and ionization, and molecular shape and size. It's also affected by gastric emptying time, so how much food or drink you have, and gastric pH, as well as the intestinal surface area and transit time. So we can delay absorption. So this can either produce a local effect or prolong systemic action. So we can do this a couple of ways. So one is to administer adrenaline with a local anesthetic, and another is the formulation of insulin with protamine or zinc. So I'll move on to pharmacokinetics. So just going to cover distribution, metabolism, and excretion. So starting with distribution of drugs. It's affected by binding to plasma proteins, the main one being albumin. So drugs that are bound to plasma proteins are inactive. So they can't enter cells or get to the brain. And because they're bound, they are also not filtered by the kidney glomerulus. So they're not excreted. That means that those drugs if there's more of the drug bound to plasma proteins, then it has a longer half-life. And different drugs can bind to the same site on albumin, so they can displace each other. Distribution is also affected by drugs' penetration into fluids, tissues, organs, fat, and the brain, and also binding to extravascular sites, including tissues, so sites outside your systemic circulation. So have a quick look at plasma concentration time graphs. So there's a few key things to note. So on the x-axis, you have time, and on the y-axis, you have the plasma concentration. So this lower green line here is your minimum effective concentration. So the concentration of the drug in the plasma has to be above this line for it to produce an effect. And at the top, this green line, that's your minimum toxic concentration. So if the level of drug in your plasma is above that, then you'll start to see adverse effects. So we want to remain within this range. You also have your Cmax, which is the maximum concentration of drug, and Tmax, which is just when Cmax occurs. You have your intensity of action, which is how far above the minimum effective concentration Cmax is, so this amount here, and your duration of action, which is how long the concentration of the drug remains above MEC. There's also the subtherapeutic level, which is just the level below MEC. This picture here shows basically the same thing, but the one on the left shows if you take one dose of the drug, it goes up to the therapeutic zone, but then eventually the concentration decreases until it's no longer effective. On the right, it shows if you take multiple doses. So each time there's a spike, there's a new dose. And you can do this to remain in the therapeutic zone so that the drug keeps having an effect. So there's two important things to note from this: the therapeutic window. So this is the range of plasma concentration between MEC and MTC, so just between the two green lines. And the other is the therapeutic index. So this is equal to an adverse dose divided by a desired dose. So basically a higher therapeutic index means a safer drug. That's because the difference between the adverse dose and the desired dose is pretty great. Okay, so drugs crossing cell membranes. So generally diffusion occurs across lipid bilayer. So the drug has to be lipid soluble. And if the drug is ionized, then lipid solubility is low. So drugs have ionized and unionized forms. And we have a measure called pKa. So that number basically says at what pH that drug is 50% ionized and 50% unionized. So we can also get ion trapping. So since only unionized forms can cross the lipid bilayer, the ionized forms basically accumulate next to it. And so basic drugs are well absorbed from a basic environment, and acidic drugs are well absorbed from an acidic environment. So on to metabolism. So bioavailability is a measure of how much drug is absorbed into systemic circulation. And so that's basically how much drug is able to actually get to the part of your body it needs to produce an effect. It can be affected by pharmaceutical formulation, absorption across the gut, and first-pass metabolism in the liver. So first-pass metabolism, so what happens is when you swallow a pill, it goes all the way down into the lumen of your GI tract, so like in your stomach. And then from there, the drug can go through the venous system to the liver, where metabolism occurs. So not all of the drug will be metabolized, but however much is metabolized in that first go, that's called first pass metabolism. And some of the drug manages to get into the systemic circulation. So anything that gets through here to the systemic circulation, that's the bioavailability. So elimination of drugs. So it can be distributed through different tissues via circulation. So it can go from your brain to your muscle. It can be metabolized, so biotransformation. So like in your liver, your gut, your plasma, or your kidneys, or it can be excreted. So your kidneys will excrete water-soluble drugs, water-soluble metabolites of lipid-soluble drugs. Your lungs can excrete gases or volatile liquids, and your gut will excrete bile and feces. It can also be excreted through sweat, saliva, mucus, tears, and milk. So we have two different orders of elimination. So zero order and first order. So in zero order, this green line here, the rate of elimination is constant. So the half-life varies depending on how much drug you have. For first order, the rate of elimination is proportional to the concentration. So this one has a set half-life. So that's the main difference between the half-life. Half-life varies for zero order, and first order, the half-life is set. This is important to know, so make sure you take note of it. Okay, so now I'll move on to drugs acting on the nervous system. So we have adrenergic and cholinergic as your two types of nerves. So a way to remember it is adrenergic is like adrenaline, so the adren part, and cholinergic, acetylcholine, so the colon part. So your adrenergic includes your sympathetic nerves, so your fight or flight response. And your cholinergic has your parasympathetic and your somatic. For adrenergic, you have alpha and beta receptors. So in your gut, you have both alpha and beta. Your heart has beta, your lungs has beta, and your blood vessels has mostly alpha. While for cholinergic, you have nicotinic receptors activated by nicotine and muscarinic receptors activated by muscarine. So the location, so in your skeletal muscle, you have nicotinic receptors and its somatic nerves. In your GI tract, you have muscarinic receptors and its autonomic nerves. In your heart, you have muscarinic and its autonomic. And in your blood, you have muscarinic, but it's not innervated. Just a bit more info, adrenergic can be blocked by cocaine, and cholinergic can be inactivated by enzymatic breakdown, so acetylcholinesterase. Okay, so we just said somatic nervous system and parasympathetic nervous system were cholinergic. So that means that they have nicotinic and muscarinic receptors. So over here, your somatic nervous system, it only has one neuron and it releases an acetylcholine neurotransmitter and it goes to a nicotinic receptor. And the effector organ is skeletal muscle in this case. For your parasympathetic, you have preganglionic and a postganglionic neuron. So at your preganglionic, acetylcholine is your neurotransmitter and you have a nicotinic receptor. While postganglionic, you have acetylcholine as your neurotransmitter again, but you have a muscarinic receptor this time. For your sympathetic, so that's your adrenergic. So sympathetic, there's two different ones because this is the second line is a special case. So the main one is preganglionic, has acetylcholine as your neurotransmitter, and it has a nicotinic receptor. While the postganglionic has norepinephrine or noradrenaline as the neurotransmitter, and it can go to either alpha or beta receptors. There's this one special case where acetylcholine, the neuron synapses at the adrenal medulla. So it has an acetylcholine neurotransmitter, which goes to nicotinic receptors. And the adrenal medulla then releases adrenaline, also known as epinephrine, into your blood vessels. So then that's just a special case. So the main thing to remember here is that any neuron that comes from the CNS will always have acetylcholine as your neurotransmitter and a nicotinic receptor. It's the ones at the end that change. That's just another diagram showing similar thing. Okay, so quick look at cocaine. So stimulant drugs like cocaine, nicotine, and amphetamines, they increase postsynaptic transmission. So what they do is they block reuptake pumps. So dopamine remains in the synaptic cleft. So that means more is released. And dopamine goes through a reward pathway, so it enhances feelings of pleasure and increased energy alertness, and it's addictive. So looking at neuromuscular blocker drugs, we have two types, non-depolarizing blockers and depolarizing blockers. So the green ones that are highlighted here are on the core drug list, so you should remember them. So looking at your non-depolarizing blockers first, they're competitive antagonists of nicotinic receptors. So examples are rocuronium and tubercularin. So a way to remember it is, rocuronium sits like a rock in the N receptors as antagonists. So these drugs do not cross the blood-brain barrier or the placenta. And you can overcome the action of these drugs, so oppose the action, by increasing the concentration of acetylcholine. So for example, if you give pyridostigmine, that's an example of an anticholinesterase that would go against the actions of these non-depolarizing blockers. For your depolarizing drugs, they're blockers, but they're actually agonists. So they stimulate the nicotinic receptors. So the action of these drugs is potentiated with an increase in the concentration of acetylcholine. This means that the effect is greater if you increase the concentration. So what these drugs actually do is they prevent cycles of depolarization and repolarization by inactivating the sodium channels. So they basically keep it in a prolonged state of depolarization. So this inhibits muscle contraction. And an example of one of these drugs is dexamethasone. Okay, so envenoming. Basically, if it's poisonous, you have to ingest it to be affected. If it's venomous, it'll bite you and you'll be affected. So treatment, you can have monovalent or polyvalent. So just one drug or multiple drugs of antivenom and pressure immobilization. And then there's a number you can call. And the other important part is LD50. So lethal dose 50%. So that's the amount of substance that is required to kill 50% of the test population. So just a couple of questions, just to double check your understanding. So which one of the following statements is true? Okay, so statement A is true. So drugs that are bound to plasma proteins are inactive. So we said before that a higher therapeutic index is safer, and the pharmacokinetic phase is what the body does to the drug. And for statement D, drugs with zero order elimination have a varied half-life because they have a steady rate of elimination, while first order elimination has a set half-life because it has the rate of elimination proportional to the concentration. And one more question. So what neurotransmitter is associated with the postganglionic nerve for the sympathetic nervous system? So the answer is noradrenaline. So that's just something you're going to have to remember. And now on to anti-cancer drugs with Stella.
You see that? Yes, no.
Oh, yeah. Wait, that's my diagram.
I know. I'm just showing it to them.
Cool.
Because you didn't get a chance. So this is what Malika was talking about, and I really like it. It's a good summary, which you can learn in your own time. So anti-cancer drugs. This is just a random fun fact. They're also called anti-neoplastic drugs, and they're called anti-neoplastics on ePharmaco. So if you're struggling to find it, that's where they are. And yeah, neoplasm means cancer because neo means new and plasm means shape. So anti-neoplasm is like anti-new shape, and that's what they call cancer. Okay, moving on. So I talked before about how we should classify the drugs before we start learning them. And so cancer is one of those kind of broad categories. And we divide it into mainly your classic drugs and your novel drugs, novel meaning new. And a lot of your core drugs are your classic ones, and a lot of the newer ones are kind of more experimental, or they don't act as directly on the cancer. And of course, there's also other supportive therapies, which we won't go into too much detail. And again, just to note that anything in green is a core drug and anything in grey is an example covered in lectures or additional examples that technically aren't testable, but they still might test you. So just an overview of the features of cancer cells. And we went through this a bit, well, in quite a lot of detail last week, but in general, remember that cancer cells are rapidly dividing. They don't apoptose and they start to kind of misshapen. And they become very undifferentiated, unspecialized, clumped together. And so that's one of the key things that we can use to differentiate and target these cancer cells. However, when you target all cells that are rapidly dividing, you also target other cells besides cancer cells, because there are other cells in the body that also are dividing rapidly. We have some examples here: skin, hair, red blood cells, egg and sperm, and these are the reasons for a lot of the side effects of cancer drugs. So if you're targeting the rapidly dividing cells in the sperm, a result is that a lot of cancer patients become infertile. How do we manage these adverse effects? There's of course a whole lot of ways to manage these adverse effects. Two ways that are pointed out to you in your lectures are antiemetic drugs, which kind of help with vomiting by blocking the relevant receptors, and colony stimulating factors, which help to proliferate the hematopoietic stem cells that were affected by the drugs. Okay, going into classic cytotoxic agents, the first one we're going to talk about is alkylating agents. And cyclophosphamide is the core drug. And what alkylating agents do is kind of in the name. They add an alkyl group into the DNA. And as you can see here, between guanine and guanine is like the typical site of action. And when you connect these, you create these crosslinks that make the DNA unstable, causing stress. And when the DNA breaks, the cell apoptoses. And this works on any stage of the cell cycle. The next one is cytotoxic antibiotics. Again, it's quite in the name. It's basically an antibiotic that was originally made for bacteria, but they found that it was very, very strong and could be used for cancer. They target cells with a high turnover rate, and there are some drug interactions which are important to kind of just know that they happen. Your antimetabolites affect the metabolism of the cell. 5-fluorouracil, 5-FU, is quite a significant one used in cancer treatment. It's S-phase specific, and if we look down here, you can see how this is what happens in a cell. This is how DNA is synthesized. And thymidylate synthase is an enzyme. And what 5-FU does is it blocks the enzyme. And if that doesn't work, then your kind of chain of DNA synthesis is blocked. And therefore DNA can't actually be produced. And that's why it's S-phase specific, because it only works when there is synthesis of DNA. Methotrexate is an antifolate. What folate is a type of vitamin B, and it's very important in DNA synthesis. So a lot of times pregnant mothers will have to take folic acid, and that's a supplement because it's so important to DNA. And when you block that chain of synthesis, then again, DNA can't be synthesized and the cell dies. This is not core. Your histone deacetylase inhibitors affect histones, and it's these ball things. They're a type of protein and they make up DNA. So if they're being inhibited, then the DNA dies and so does the cell. Plant alkaloids, again, not core, but also discussed. Mitotic poisons. Just remember mitotic, mitosis, mitotic spindles in mitosis can't be formed. And this is MPhase specific. Topoisomerase uncoils DNA so that it can be replicated. And obviously if it's inhibited, then the DNA can't be unwound as well and becomes unstable and unusable. Hormone and hormone antagonists, and these are used for specific types of cancers. So in breast cancer, we have tamoxifen, which is a selective estrogen receptor modulator. And what it does is it acts on different parts of the body differently, hence it's called a modulator. So in the breast, it is an antagonist for estrogen. If we look over in the diagram, you can see it's blocking the estradiol, which is a precursor for estrogen, from from binding, and therefore it can't proliferate the cell. Another important breast cancer drug is anastrozole, and aromatase is important to convert androgen to estrogen. So when you inhibit that enzyme, then you decrease the amount of circulating estrogen. Another example is prostate cancer, anti-androgens, and I'm going to say GnRH analogs. So androgens are hormones that kind of help display male traits. And if you block them, then you reduce the growth of these cancers that require the sex hormones to grow. With GnRH analogs are anything that sort of copy or like simulate the shape and the molecular structure. And with analogs, they can be both agonists or antagonists, but most of them that are used in prostate cancer act to stimulate the gonads. For blood cancers, such as lymphoma or leukemia, we use glucocorticoids as one possible treatment. And glucocorticoids are a type of hormone that's produced by the body. And while these are found to be particularly useful in blood cancers, they also have other purposes and other uses that you'll learn more about in semester 2. Moving on to novel agents, monoclonal antibodies. These are my favorite to recognize because you literally have to remember that they end in MAB. So anything that ends in MAB is a monoclonal antibody. And the 2 on your core drug list are there. The idea is that these are basically antibodies produced in a lab to fight cancer. It does, however, carry the risk of an immune reaction because they are lab produced. This is a general schematic of how these monoclonal antibodies are produced. You don't need to know it in too much detail. Basically, just know that they're produced in the lab, and by taking the antigen and growing specific antibodies, we can kind of choose which antibodies we want and which ones are suitable and actually grow them to use. The next novel agent is biological response modifiers. Again, in the name, rather than attacking the cancer, what we're doing is now improving the immune system, and how we can do that is by bolstering up interferon or interleukin-2. And by doing that, we're just kind of either increasing how kind of strong or cytotoxic the immune cells are, or increasing proliferation and cellular immunity. Intracellular signaling molecules. So in order for cells to proliferate, they have to kind of communicate. And how cells do that is there's like a lot of pathways in the cell. And think of it as like a chain reaction that you're triggering. However, if we can block one of those pathways, then that chain reaction can't happen. And so that's what these drugs that inhibit protein kinase does. The issue with that is it can only suppress one of many enzymes because many different enzymes are involved in this sort of chain reaction. There are many chain reactions happening at once, and that's kind of one of the drawbacks. Sensitizing agents, as the name again suggests, it makes the cancer more sensitive, so more recognizable by the immune system and more likely to be attacked by the immune system. Now, what could go wrong? Firstly, we could have drug resistance, which is a problem, which is a huge problem in pharmacology in general. And we can overcome that by possibly going on a drug holiday where you give the patient no drugs so they can recover from the toxicity. Or you could do the opposite and go for more drugs and kind of overcome it by attacking all the different pathways at once. Tumor cell sanctuaries can occur, which is when kind of the tumor cell hides away. So after the drugs have finished attacking, these tumor cells lie dormant, and that carries the risk of relapse. So the solution to that is pretty much just surgery or radiotherapy. Dose exhaustion is when you can't give any more to the patient. Any more than that would be toxic, and that the patient can't fight it. And once you reach dose exhaustion, you can either go for, again, surgery, radiotherapy, chemotherapy, or go for a combination of different drugs. Okay, quick questions. What phase of the cell cycle does methotrexate affect? I can't actually tell if anyone's answering. But yeah, okay. So, S phase, synthesis. Remember that the antimetabolites affect DNA synthesis, and synthesis is your S phase. Which drug is most useful for a 54-year-old with breast cancer? So as we went through before, tamoxifen was your selective estrogen receptor modulator. As you can see here, it is an antagonist. Or is it? No, never mind. Oh, here. It's an antagonist. Anastrozole, again, inhibits the conversion and the creation of estrogen. Doxycycline, an antibiotic, you don't need to know that yet. GRH for prostate cancer. The rest are irrelevant. Okay. Next slide. So, does anyone have any questions?